Yeah, morning. We
Yes,
see
good
you.
morning. Welcome
Morning.
to our hybrid OR in Hamburg. Can you hear me, Thilo?
Yes, we can hear you. It's Martin
Okay,
Grabenberger. We hear you
good
and
morning.
see you.
Perfect. Yes, we are about to prepare our next case, but we want to go back to our yesterday's case, which we were not able to present live, but can do now, our live edited version of it. So I want to introduce the case first. This was a Tevar and candy plug case in a, next slide please, type B dissection with false lumen perfusion. The patient already had Tevar and carotid subclavian bypass procedure, but showed a SINE, a stent graft-induced new entry tear to the false lumen, which is depicted in this draft. Next slide, please. So our treatment plan was to extend the true lumen stent graft distally to the celiac trunk and also occlude the false lumen and prevent backflow with a candy plug and use the classic candy plug technique. Next slide, please. We can see the candy plug here now in the perfect position in the draft on the right side. And to access the false lumen, I have a picture of the left common iliac artery where we can see the dissection membrane and access to both lumina. Next slide, please. This is a draft of the candy plug we use. It's a different shape. It's not a candy wrapper shape any longer. We have now a longer sealing due to the tube graft shape of the candy plug, and it's a diameter of 46 in the maximum of this graft. Now we can go to our case from yesterday, please. We have a edited version, and we can see here now the first angiography we did, and we can perfectly see the huge entry tear distally to the true lumen stent graft, which was already in place. We can see good perfusion from the true lumen of the celiac trunk, SMA, and right renal. This is the CIDR overlay we were able to use, and we see quite good overlay from CIDR. And this also helped us to orient for the level of the celiac trunk. So the next step is here that we first took a look at the previous procedure, and we can see that the patient has an Advanta stent graft for chimney. Here we can see our true lumen stent graft, and it's crucial to not oversize the stent graft too much in the true lumen. So I decided for a double tapered device with a 42 diameter proximally, tapering down to 31. Here you can see how we advanced the graft. We of course made sure with our angiogram that the stiff wire goes through the true lumen, and we wanted to make sure that we also have an overlap of at least two components to the previous stent graft, and this is how we position the graft. We want to land distally above the celiac trunk, and this patient has quite nice anatomy to make that possible. Of course, CIDR overlay is helpful here, and we knew already the position of the celiac trunk, so we could position our angiogram catheter here, quite nice at the level of the celiac trunk, and we see the distal ending of the stent graft in a good position, and we were happy with that. The deployment is not shown, but here we exchanged the 22 sheet to a shorter 30 centimeter sheet to catheterize now the false lumen for our candy plug technique. And this is a nice angulation where you can see the dissection membrane separating true and false lumen, so it was quite easy to get into the false lumen from this position and advance the wire. And we were quite sure to be in the false lumen here. As you can see, it goes beside the stent graft. We knew from our CT scan that there was a little bit of thrombus, but we're able to access the thrombus also. You will see that shortly in an angiogram. But it's crucial to make sure that the false lumen can accommodate the stiff wire and also the delivery system of the candy plug. But this was possible here, and we advanced the stiff wire here into the false lumen next to the true lumen stent graft, did an angiogram, and here you can see the perfusion and backflow and pressurization also of the false lumen in this angiogram. The candy plug position should be aligned distally with the true lumen stent graft into the false lumen to act as a counterforce also and prevent also stent graft induced new entries at this level. And here we see the candy plug in position. So this is the perfect position. It's also crucial to get a nice angulation where you can see the separation of the true and false lumen. And the candy plug here is deployed. And we want to make sure that we really are aligned distally to the true lumen stent graft. And you see the markers of the candy plug. The stent components are marked with distal markers, and the tail of the candy plug, which is released now by the sheath, is also marked with 2 gold markers, this Cook device, and this closes without an extra plug. So we don't have to add any more steps. The candy plug now, the channel, the Frappic channel tail closes after the dilator tip is removed by the tension which is produced by opening of the stents. So here we see now the top cap, the top stent opening and retraction of the dilator nose. And this is our angiogram after we deployed the candy plug, and we see that false lumen backflow is prevented by the plug. Yeah, so this is a good alignment of both stent graft, true lumen and false lumen stent graft. We have a nice sealing zone. This is our final angiogram, and we see a good perfusion of the supraaortic vessels. We see complete seal of the entry tier, and we see good perfusion of the celiac trunk and no backflow into the false lumen any longer.
Thanks very much. Very nice case, very nice completion. Angio at the end, complete closure of the false lumen, at least in the thoracic part. Yes?
Fiona, good morning. This is Stefan.
Right.
Can you tell us how you sized the candy plug, please?
Yes, the candy plug, different than the true lumen stent graft, should be oversized to the maximum diameter of the false lumen 1 centimeter above the celiac trunk. So there should be an oversizing of 10 to 30%. This should be ideal, so for the candy plug. So there should be an oversizing, not in the true lumen stent graft.
Is this candy plug already commercially available, or is this a homemade product? Because
this is a CMD device, yes, and it has to be ordered according to the patient anatomy.
Are there any questions from the auditorium concerning this case? Yes, one question.
That was a great presentation. Did you closed off the entry tear and the false and true lumen to the intercostal arteries? Do you do any neuromonitoring or CSF drainage?
Not in this case, no, because we knew from our previous CT scan that there were not so many intercostal arteries going from the false lumen. There were mainly intercostal arteries, also not in the section we were occluding in this procedure. So we didn't worry about that too much, but of course we paid attention to a good mean arterial pressure after the procedure for the patient.
A question from Gerd Willem.
Hi, Dr. Schuring. I did one of these candy plugs, and then I was told to push up the tail. I didn't see you do that, and in my case the celiac trunk came from the false lumen. So now your tail is hanging into the false lumen.
Right.
You don't push it up anymore?
Yeah, this is a very good point. Actually, we did, but it didn't stay there. But in this patient, we didn't force it because the main arteries were coming from the true lumen, and we were not concerned about the left renal artery, which arises from the false lumen, because it was not perfused well already, and the kidney is not working on that side. It's already it was not perfused initially. So we didn't worry about that too much, but this is exactly a very crucial point, and it's good that you mentioned that. So
Okay.
it should be tried, if possible, that this tail can be pushed up a little bit.
Thanks very much. Thanks for presenting this excellent case, and we proceed with our program here in Essen. Yes, thanks very much.
Thank you.
Bye-bye.
Bye.